Great. Good afternoon, everybody, and thank you, Margaret. Well, in this presentation, I'm going to be echoing many of the points that Jordan raised and also Michael. And I think it's great that we're almost at a moment of time where, particularly across the professional societies, there's a convergence now of messaging, and I think it's very important that we build on that now and amplify those very clear messages. Well, in this presentation, I think we're about 10 minutes late, but I'm going to speak fast and hopefully we can catch up. But I'm going to cover three main points. First, on the imperative of why simplified service delivery is needed. And then the WHO approach. That was what I was asked to focus on in terms of simplified algorithms, the integration, decentralization, and task shifting, which we heard about. And I'll be presenting some, I think, very new, compelling evidence that really supports this approach through a recently completed systematic review. And so, in turn, the need for simplified training of the health workforce and the role of new diagnostics. And then I'll end with a kind of potpourri of some different examples of how these individual components of simplified service delivery have been put together to deliver with the goal of elimination in different settings. So just to set the scene on what were the simplified service delivery good practices that we highlighted in the Hep C guidelines, but applied equally so to hepatitis B. And the ones I'm going to focus on in this presentation are the simple and standardized algorithms, the critical importance on various steps to strengthen the linkage to care, integration, decentralization, and task shifting. That's what I'll be able to cover this time. Michael covered well the issues of community, which is absolutely center stage, and this is something we reinforce again and again, but I won't cover that with further examples. And then the importance of the efficient procurement and supply management of both drugs and diagnostics, that a perfectly simplified pathway will do no good if there's constant interruptions with supply of RDTs or the drug supply. So we learned so much from HIV on the critical importance of decentralization. Decentralization coupled with task shifting was absolutely transformative in the scale up of ARVs, particularly in sub-Saharan Africa. And the decentralization happened. It didn't wait for cluster randomized trials. It happened, and it could happen because we had global funders and procurers, be it PEPFAR, be it Global Fund. And so it rapidly became established and dramatically reduced the time to be put on treatment and the overall treatment uptake, a real success story. And so in turn, the demonstration that task shifting to nurses and non-specialists achieve comparable results. So why is simplified service delivery such an imperative with hepatitis? Well, this shows the status of our progress on achieving the main service delivery targets. And the shaded, the pale colors are representing the 2030 targets, and the dark bars where we are on achieving those targets. And I think what is clear from this slide, focusing on the dark bars and where the circles are, is that if we are to achieve the overall goals of elimination, both mortality and incidence reduction, we have to have a radical scale up in testing and treatment. This in turn requires a radical simplification. And because 80% of the burden for both hepatitis C and B is in low and middle income countries, and there are health care worker shortages in those countries, so in turn to achieve the scale up of testing and treatment, we need the simplification and task shifting. So, good practice one. coming from the WHO guidelines. So I think what we set out, and this was actually going back to the end of 2016 when we produced these simplified algorithms, and I think has been a very important step forward. And I think with the Hep C algorithm, which was the easiest one to simplify, removing the need for a liver biopsy, removing the need to do repeat RDTs or to do a confirmatory EIA on serology, removing the need to do on-treatment evaluation of viral load, to really now 5 simple steps. A single quality assured RDT, and then very, very important is this prompt or lab reflex NAT or core antigen. So many people are being lost before viral load that simply taking that sample, having the patient wait 5-10 minutes and getting that sample straight away really has an important contribution to reducing loss to follow-up. The use of non-invasive tests, particularly the APRI, the FIB4, and FibroScan if available, and then of course now with use of pan-genotypic regimens dispensing with the need for genotyping and the single test of cure. As Jordan has highlighted, we're just not there yet with hepatitis B. I think when we came out with this algorithm in 2015, we thought it was super simplified compared to some of the original, professional society guidelines. But the fact is that only a proportion will need treatment, and you can't always make that decision on a single visit. And what I've seen in various countries where I've been visiting, it's that need to come back for further liver function tests that where people are melting away. And so this is the challenge, and I think this is the next goal we need to work towards to achieve the same level or some degree of simplification. I think Jordan also mentioned what is a major challenge in so many countries is the issue of case finding. It doesn't happen on its own. You've got to be strategic in who you're going to test, where you're going to test, how you're going to phase it in. And again, the WHO testing guidelines elaborated on all these different scenarios, as well as collating the evidence base to support the focus testing in most affected populations, as well as when you might consider extending to general population testing and how that would happen. So this is just the kind of approach of mapping all the different testing opportunities and testing settings, particularly where you've already got testing going on for HIV or TB or in antenatal clinics, and mapping out who you're going to do a risk-based assessment and who you're going to really test everybody in that clinic. And that is very much what needs to happen. And in the phase 1 and phase 2 charts I've shown on the right are some of the kind of practical examples in our working countries where we're trying to say, start here, start with the low-hanging fruit. And when you've accomplished that in your STI clinics or your prison populations or PWID or those with clinical suspicion, with posters up around the hospital to really get that message across, then to consider community awareness or alongside community awareness raising so that you bring in some of the other groups in the population, to those with tattoos who've had blood transfusions some time ago, and piercing, etc. Good practice 3 that I've already mentioned, linkage is key. We learned this from HIV, and from a number of systematic reviews we did to support the testing guidelines, several key interventions come out quite clearly. And I think I just want to reinforce some of them. I think the integration I'm going to come back to in a minute, the on-site rapid testing, the use of immediate or reflex nucleic acid testing, and then the use of peer workers to support linkage, assistance with transport, some very practical steps. And it's amazing, I mean, I think we all assume that everybody's doing rapid testing, particularly in low and middle income countries, but I recently just returned from Malaysia, where this was a major sort of paradigm shift to introduce RDTs at primary care level for hepatitis C. They'd certainly done it for HIV. So I think it's not an automatic thing, even though they're widely available and there are several pre-qualified. I think there's also been a lot of debate about the role of some diagnostic technologies in simplification or promoting access. And I think the point of care viral load is a case in point. This just summarizes some collaborative work we are doing with FIND, supported by UNITAID in multiple countries and multiple projects, looking at the contribution for having a point of care viral load, be it at a harm reduction site or in primary care or in an ARV clinic, to really speeding things up. And I think key message from this, and this is just focusing on some preliminary findings from Georgia with FIND, the arm 1, which was the point of care viral load at the harm reduction site compared to sending a sample to the centralized facility for core antigen or NAT PCR, absolutely, it sped up the time to get the result. But the patient was still being referred elsewhere for treatment. And so unless you are able to provide treatment at the site, many of those early benefits of getting your viral load result don't translate into an overall reduction of time to treatment and cure. And that's absolutely critically important, that a good technology does not replace the need for having simplified service delivery and testing and treatment at the same site. And I think just to flag, there are many other emerging technologies that may have a role in promoting access and simplification, at least in access to testing. And we're currently working again with FIND in a number of countries, evaluating the contribution of hepatitis C self-testing, which will have a sort of slightly different positioning than HIV, and doing similar work on the use of combo RDTs for HIV, hepatitis B, hepatitis C, and syphilis, and whether that promotes uptake. So I now just want to move on to the systematic review that I mentioned, that I want to share with you. This is just recently being completed, that I really think now provides very strong evidence for this full decentralization testing and treatment at the same site, as well as for task shifting. So we identified 140 studies across 33 countries. About 14% of them were from low and middle income countries. We really tried very hard to identify all the ones out there. Some of those were unpublished. And this shows the district characteristics, these 140 studies. A significant proportion, 56%, were among persons who inject drug, 19 studies in prison populations, 5 PHLIV, and then 37 in the general population. Relatively, only a third had outcomes across the entire cascade of care. More of them were focused on the treatment part of the cascade. Majority were using DAAs, and relatively few had a comparator study design. And we define full decentralization as where you do testing and treatment at the same decentralized site. Partial decentralization, which is quite common, where you do testing in primary care at the harm reduction site and then refer for treatment. And then the task shifting, non-specialist nurses, primary care physicians. And you can see that we particularly had many studies among PWID for the full decentralization, and similarly for the task shifting. So there's quite a wealth of literature in that area. So the next few slides are the main messages from this systematic review. First, and this is comparing full versus partial, and this is in the PWID and prison population. On the left, PWID, on the right, prison population. And what it shows, and just focusing on the point estimates, full decentralization compared to partial improved the uptake for testing uptake quite substantially in both these populations. Similarly, for linkage to care, again, PWID on the left, prisoners on the right, it also increased linkage to care significantly. No great surprise if everything's been done on the same site. And furthermore, as a result of that good linkage to care, increased uptake of treatment, which is the ultimate goal. And then, also importantly, it showed comparable SVR rates in the fully decentralized compared to partially decentralized, compared to no decentralization. That's the specialist or tertiary care facility. So this is very strong and consistent evidence. And what was also interesting, it wasn't just in the OST sites. We were seeing this impact of full decentralization also at the NSP sites. So treatment was taking place mainly in high-income settings at the NSP sites as well. In the general population, the evidence was less compelling. I think there are fewer models out there. The models of care in primary care have not been fully established. Similarly, we showed that task shifting to non-specialists in both PWID and the general population, shown there on the right, showed comparable SVR rates. So quality of care as determined by SVR was strong. But in order to deliver task shifting, we need to simplify our training and approach to capacity building. And I think this is an approach that we, working with the University of Washington, we developed, which was really to have a toolkit approach. The different ways you can approach initial training, either through online training, workshops, combined with ongoing mentorship, be it through WhatsApp groups or be it through tele-echo, tele-mentoring, e-consultations, and then further supported by other sort of web-based and electronic clinic support tools. And so this was the sort of menu that we felt countries, ministries of health can use to adapt for their own particular situation. And I think there's some really excellent online materials out there that people can use for their own training, initial training, that have MCQs at the end, have clinical scenarios. But they do need to be adapted more for low and middle income country settings, that the regimens and the approach are not sufficiently adapted. I think there's also some excellent workshops out there and some very good examples of these workshops being combined with on-site clinical training, WhatsApp group, and ongoing mentoring. So many variations on a theme. And then, of course, the Project ECHO, which many of you are familiar with the, and Punjab, India, has established an excellent tele-echo program with now more than 200 physicians